ABSW and HAAC COVID-19 response and impact team. And tonight we are going to we're going to go through a few of the sort of key factors or key points about our initiative. But first of all, I want to have Veronica introduce herself to you, and also to ask Veronica to take us to a little bit of a moment of silence, because we have had some very sad things happening in our communities, and we want to acknowledge that. So over to you, Co.
Okay. Hello, everyone. Yes, as Sharon has indicated, I'm Veronica Marsman Murphy, otherwise known as Veronica Marsman. And I am a social worker by trade for almost 40 years now, and I'm on the downscale. I'm at the point now where it's like I'm looking for the youngins to take over. Sharon and I have been managing this COVID initiative since inception. And I was a manager. I retired from the Department of Community Services about 10 years ago, went into the private sector, and spend a lot of my time now in the community doing voluntary work. So that's a little bit of who I am. But as Sharon has also alluded to, we lost daily, it's almost daily that we're losing people in our community. But this week it really hit hard when two members of one family, we lost them, one being Sister Alma Johnson. Most folks, I mean, raise your hand, how many know of Sister Alma? She's been around everywhere. Sister Alma is a long-standing member of the AUBA, which is the African United Baptist Association. She served on many committees in that organization. Most notably for her, it was the historical committee. She was really big on the history of African Nova Scotians and the AUBA. And she was also on the case, what is it, the
Council on African Canadian Education.
That's the one. For a number of years, a number of terms she did on that. And she passed away on Wednesday, I believe, of this week. And then yesterday, we received information last evening that Reverend Tracy Gross from Cherrybrook Lake Loon, both of them are from Cherrybrook Lake Loon, she also passed away. Reverend Gross has been ill for about the past couple of years. She was the first female pastor of the AUBA, so broke lots of barriers there, because as we know in our churches and in our community, in our society, how males in ministry, and so she was able to fight through that. She was the first AUBA pastor, as I stated, and so yeah, we just want to have a moment of silence and recognition of these two honorable people. And also Sister Alma, I believe, was also, I'm told, was a member of HAAC. So. Well, thank you everyone for taking time, and I do ask that you keep those families. Both of them are, let's see, Alma was Reverend Tracy's aunt, so they're connected. Is that right, Karen? Aunt, yeah. So it's definitely in the family. So we ask that you keep that family in their prayers, because they're being hit twice this week. All right, so with that said, we'll get on to the business at hand. I'm here to talk to you a little bit about the toll-free line, to let you know that it's still in operation, folks. We are still receiving calls to the line. It has dropped off significantly But we're probably getting anywhere, maybe around 15 calls throughout the month for needs. The rest of the calls, we're probably getting about 40 calls on the toll-free line, but a lot of them are for social work intakes. There's a lot of needs out there right now that are challenging. You know, there's the COVID needs, but then there's housing and immigration. We're getting immigration challenges that we're being faced with. So we are still operating the lines. We have 3 people that are staffing it on a daily basis and responding to the calls that come in. Still some food challenges, but we're referring those through to the food bank. So yeah, what else? Any questions on the toll-free line and what we're doing there?
I'm just wondering, Veronica, if you could sort of give us a little bit of a background, because some folks aren't even really aware of the initiative. So how we came together and what we were, yeah.
Okay, so back in March when COVID first came to light, and wow, it seems like, yeah, it's almost like a lifetime ago. So that's back in March when government identified that, you know, COVID-19 was out there. HAAC immediately rallied together and we initiated the first Zoom community meeting, basically to give everybody a sense of what this COVID was about, COVID-19. We had, I think, Dr. Gaynor, you were on that one as well. Any questions, medical questions that people had, that was the first Zoom call. And there's been several since then. Then in March 22nd is when government announced declared the state of emergency. And that's when we knew we were in trouble. Things were ramping up at that point. ABSW at that time established a provincial toll-free line. We knew that that our community members, the African Nova Scotians, we needed some resources and we would need some help. And where else were they to go? So we established the toll-free line on April 1st, and it's been going ever since. And then immediately we recognized that it was bigger than just ABSW. And that's when HAAC, we partnered with HAAC, and we partnered with HAAC on a number of other initiatives as well. So it's not like it was it was a marriage that we already had. And then shortly after we got ourselves together, then we formed the response team, which is now the impact team. And that's, again, bringing a number of partners to the table. Some of the folks that sit on the impact team are actually online tonight, like Karen. Karen brings our educational information, our resources to the table. People at the beginning, we were getting calls from parents because if you recall, in March, the kids went home because it was March break. They didn't get to go back to school. So they left because we were getting calls from people saying they wanted educational supplies. And I'm like, educational supplies, they should already have that as parents. But because they had left their stuff at school, then our parents were like, I'm out. I don't have the means for this. So Karen rallied together. She was able to get educational supplies. We know what education is for our Black learners. We wanted to ensure that they had the appropriate resources so that they would not fall further behind in their studies. Dr. Haase and Donna Smith were our health from HAAC, our health representatives from HAAC. And so again, any questions that came in from people, pertaining to health issues, should I do this, should I do that? Those questions would be referred to our health people. If there were questions coming in, because we were fortunate enough that we had Rhonda working right in the health system. So that we received early on lots of calls from people saying, hey, I was tested 5 days ago and I haven't heard the results yet. We could refer that to Rhonda, who could then check with her health folks to say, hey, it's not supposed to be 5-day turnaround. It's supposed to be a lot quicker than that. So every call that came in was triaged to a number of folks. We also had on the team, oh gosh, let me see here. We had
Reverend Beal.
Reverend Beals, as we know, being a lot of spiritual people that we have within our communities, people were, and the number of deaths that are still continuing, people were grieving and people were anxious about it. So we had resources through Reverend Beals, and it was a team partnership. She wasn't doing it alone. It was in collaboration with Donna Smith and through HAAC. So we had the spiritual needs being taken care of as well. Then also on the team, we had government resources. Department of Community Services, otherwise known as DCS, came to the table immediately and provided numerous food boxes. They not only provided the food boxes, they shopped for it, they got it together, they distributed it, assisted in the distribution of it. So that was, we were very fortunate to have them on board. And then also Tracy Thomas from the ANSA office. So if we had any concerns in terms of where things should fit within government, Tracy was our contact. And then the other part of our team was our community intermediary. As you guys know, when we first initiated, when we first started with this, with the COVID response, one of our Black communities in particular was hit hard. And so we needed to be on the ground immediately. And Regine Willis, who's from one of the communities, was our community intermediators, what we called. So she was the link. Anything that came in from the community, it was a question, we would flip it to Regine, who then would flip it to the community coordinators. Every community, no, not every community, every region in our province has a community coordinator. And so Regine could take those questions and concerns to the coordinator, who would then resolve it in their, or assist to resolve it in their area. So that's how we got started. It was a rapid response, folks. As you know, this was, we were out the gate. We had to develop things on the moment, at the moment. Confidentiality forms. People are calling in. We had volunteers working the line. We had to develop confidentiality forms for them. And even people going into people's homes or dropping things off. Timesheets, schedules, like all of those things were being done on the spur. So just as rapidly as this COVID thing was changing, we were changing to meet the need as well. So there was lots of action taking place. We were working, well, you guys can all attest, the ones that were on there, we were working easy 12 to 15 hours a day at this initiative. And I'm so pleased it's died down now to a couple of hours, an hour a day. You know, it feels so much better. It is a provincial scope, even though when we first started, it was very much a township initiative, it appeared. But quickly we're able to rally ourselves together and say, okay, we're here for all of our communities, all peoples of African descent in this province. And as I stated, we have coordinators in all of the regions. So the toll-free line, yeah, it's still in existence. And the coordinators cannot do it alone. They had a bunch of folks on the ground helping them. Because when it came out to distribute flyers, you couldn't expect one person to do it. And so the funds, were really pleased that we received funds immediately from ANSA. When we jumped out at the gate with the toll-free number, ANSA came to the table and said, okay, here's some funds to manage that, to get things going. Then the Department of Community Services, through other government departments, came to the table and said, we will provide you some funding as well. And who else provided us funding?
I can talk about the Canadian Red Cross.
Okay, but there's United Way, Good Food, Canadian Foundation. Those were other funders to this initiative as well. Now, when they gave us the funding, especially DCS, and they gave you the largest amount, they gave it with the intent that this was going to last through COVID. So, you know, everybody's thinking, okay, we're going to be finished with this May, June. What we did is we said, we're not sure if we're going to be finished it, and we're still on the clock. So we took some of those funds and we're stretching them to take us to next year, because that's a challenge for us. Is now that we've established the line, the calls are still coming in for various issues in our community. People are calling because they're in need. So now we're like, well, what's going to happen now for our folk? So what's supposed to happen tonight? We do not see this line shutting down even April 1st. So again, we're going to be challenged as to how we manage that and keep it going, because it is a need in our community. And then the sustainability of the resources that we are providing folks. One of the resources that we have been providing that has been well received has been blood pressure machines. And it started in the height of COVID, when seniors did not want to leave their home. They knew they needed to go to the doctor. Their pressures are increasing, but they didn't have the means to purchase a unit, which in a drugstore is almost $100. So we quickly, through our resources, seeing a bunch one day in Costco, so we could get them for $65. So we stocked up in these blood pressure machines. So once they called and once, it got known that we were able to provide that, then we were able to provide. And I like that, because you know what? COVID's gone, they still have something to hang on to, the blood pressure machine. So that's a little bit of the history, how we got started, what we've been doing, and where we're at with the initiative. So any questions or comments around that work? And I trust all of you guys received our first newsletter that went out. 8 pages it was, and there'll be another one coming at the end of November. So that's our way to keep the community informed of the initiative, let them know what we're doing. And for you, Lavinius, I'm saying it wrong, I apologize. Troy down in Yarmouth has been a godsend, helping us out to distribute things, because if somebody in another part of the province calls and there's a need, I'm not traveling to Yarmouth. So it's just a matter, and again, we had to develop petty cash forms online, and get him the form to sign so that I can transfer money to him. Our bank account just shot up at the e-transfer fees, because that's how we're doing business now.
Yes.
So we're making it happen. But if anybody has any wonderful ideas or anything that we should be doing that we've not identified or not considered, and then of course, Dr. Omar Sharif, the research grants, everybody's out there. This is a hot topic, COVID. So there's lots of research initiatives that are taking information, connecting to folks as well. So yeah, questions or comments? Have I hit it all, Sharon?
Veronica?
I have a question.
Yes, Kelly.
Yeah, just around the continuum of this, in terms of addressing issues of isolation for the seniors in the community. Is there any type of activities or work being done around that?
So did you want to go ahead with that, Veronica? And I'll add.
When we were in the height of it, we provided craft supplies to the communities and the township communities. We provide, materials, reading books, puzzles, there was a package that, even some garden stuff that were provided to the seniors who called in. Now that we've kind of died down from that, we haven't been providing as much. We did also, as many folks know, provided tablets to seniors so that they could connect, because they were isolated, not being able to even get out of their homes. So we provided tablets to them with very stringent criteria as to who was to receive them. And we still have the means to provide some throughout the province now, not so much in HRM, we're trying to take care of the rest of the province should there be this second wave, and if people are, we also provided internet access. It was a budget line for that. So although there wasn't a lot of uptake in Metro, it was only about 11 homes that identified as requiring internet. So now we do have, through the Community Foundation coming up for the fall, we do have a couple social programs. One is going to be online cooking. You know how folks receive those food boxes now? What we're going to do, working through our coordinators, is we'll have a chef, probably in Metro, who will prepare a healthy meal, or have it all be prepared online. Everybody's going to be delivered, not everybody, but probably 10 people in the various communities who will be identified by the coordinators down there, will be delivered a food box. They'll go online, so they have the food box, they have the tablet, go online, follow the chef, and have a cooking class. Same thing with the children. There's going to be children's cooking classes, as well as there's packages of games going out to the children soon. Various ages. There's the young kids package of games for them in their home, and the middle age, and then older kids. And some of them are family games to try and keep them busy at home through the winter months. We also have some funding available for heating costs, because we know people are at home more, so the heating cost soars. So for seniors, to assist them, and so we have to develop the criteria around that, working with the coordinators. So we don't say who should receive and who doesn't receive. I don't know the people in Digby or in Yarmouth as well as you guys do, so what we would say to our coordinator down there, you know, you got 10 gift cards or 10 connections for heat, you identify the people most in need. And that's one of the challenges that we had in our communities, is people trying to identify need versus want, right? Because everybody wants it, but do you really need it? And if you're taking it, you could be taken from somebody else who's truly in need. So we had some of those challenges, lots of lessons learned along the way. But do you realize, you guys, that we have a team, a structure, a process that can be utilized through any type of emergency in our communities? We're working also with EMO Nova Scotia to put this structure in place. So if there is a massive fire, or even, God help us, we come into a snow drift or something in one of our communities, we'll know how to respond more effectively, swifter, and who some of the players will be. So we're trying to set that up, working with EMO, that we'll have EMCs, which is emergency management coordinators, in each of our communities. So that's the side of it that gives me goosebumps, to think that this just isn't a one-off. This just didn't happen by fluke. It's something that's going to continue.
Yes, absolutely. And hats off to Mike Ho, and hats off to our team. We do imagine a future and an infrastructure that is never going to be taken apart. We're building something that is going to be resilient. I do think that it's a couple of people have asked questions about how we're capturing this and so on, and evaluation on it. My good policy person there, Louise, she always asks about things like that. But I can tell you that while I would be fibbing to say that, you know, I could point to an evaluation process specifically, we certainly have to report on all of our activities, don't we, Veronica?
Yeah.
And we have to, you know, even in order to get the grants. I mean, we know what we're spending. We know what we're spending it on. We have to in our writing proposals, you know, make a good case, or else there's no money coming in. And I have to say that that Veronica is extraordinarily resourceful. She finds grants that, you know, are you know, you have to find them under mountains or something. She's able to find them. But HAAC independently is a nonprofit. ABSW is a nonprofit too, but they have charitable status. HAAC does not. And one of the opportunities for nonprofits who do not have charitable status was to apply through the Canadian Red Cross. So indeed we did, and it was an enhancement to our larger impact project. And the one with the Canadian Red Cross is specifically around mental health. And so what we did, and you asked Shelley about seniors. Seniors are part of the or one group of the populations that we're trying to reach with that. But the idea is to provide online, culturally specific resources to people of African ancestry online. And so with the Canadian Red Cross project, what we had to do first, of course, was to have our community outreach people like Live in Us and Crystal States and Charles Shepherd, and there's others. I can't see everybody, but maybe they're online. But a number of those great people were able and wanted to set down in Yarmouth, able to identify people who had no access to electronic devices. So they literally had no computers, they had no iPad, they had nothing to be able to access the online services. So first things first, we had to get electronic devices to them. We had to assess who needed them, and make a project that kind of met those needs. So I'm very happy to say that we were able to, we ordered, and they are not yet distributed, but they are in the process of arriving in 3 places in the province, 97 tablets that people will be able to have access to and will be able to keep. And we have online services as well that we are connecting to. We connect the dots between one project and the other so that our people can have access to online mental health support. One of our people who's on the project that you heard about, Donna Smith Darrell, who is a past president of HAAC, she and Reverend Beals actually provide grief support online as well, and they've done some really great work. And so people will be able to have access to grief support. And as you are aware, sadly, it's been needed and it's going to be needed. And as we go through this process, I'm afraid it's a reality for us that grieving is something that is affecting us, not just the loss of loved ones, but the loss of so many things, the loss of work, the loss of peace of mind sometimes. So there's that, and quite you may well be aware of it, and some of you may be participating, but as a part of the Canadian Red Cross funding, we are also providing online yoga, meditation, and de-stress. And that's available to anyone. And that's available once or twice a week. It's the Afrocentric Mind, Body, and Breath service, which is to, they talk about breathing, mindfulness, practices to relax the body, release tension, build awareness, and reduce stress. And if I could find 5 minutes to go, I'll go myself because I really could use it, but it is available to everybody, and that is funded through the Canadian Red Cross. So that was a very long answer to your question, Shelley, but there are resources, there are online supports, and we will do our best. And we're here, we've been here, and we're gonna be here through the long run. So I'm gonna now actually get back to the pro. It is part of the program. We wanted to share that with you. I know that many of you didn't know the depth of work and the kinds of things that we've been involved in, and we're very, very proud of it, and we're very happy to share it with you. So tonight, our call is going to emphasize 3 themes. And then we're going to have time at the end for questions. So don't think that we are, if we're moving along, that you won't have a chance to ask your questions, because you will. You can ask them in the chat, but we will also have time at the end. So the 3 things that we're going to deal with tonight is an update on COVID-19 numbers and what is meant by a second wave. And Dr. Gaynor is with us to give us the real facts, and she understands we want that, but she also understands how to talk to us, because we got our own stuff we want to find out about, and Dr. Gaynor gets that. So that's why she's here with us. And she's going to provide updated information about the virus, staying safe, testing, when to ask for help. We're also going to, and Dr. David Haase is going to be doing that as well. We are going to also be talking about mental and physical health, keeping healthy. Our own Rhonda is going to introduce herself, tell you about her role both with Nova Scotia Health and then with our project. She's going to talk a little bit about that. And then we are so pleased that Karen Hudson, our education coordinator, is with us, and she's going to talk to you about schools, where we are now, what we have to be ready for, because you have to always be planning just in case. So that's kind of how it's going to go. And without any more delay, I would very much like to ask Dr. Gaynor to introduce herself, tell us about your role, because sometimes it's such a mouthful, Dr. Gaynor, that we could get confused. We wanted to make you Deputy Minister of the Department of Health and Wellness. I still would like to see that. But anyway, moving right along. That's not what your role is at the moment. And so if you could tell us about that and share with us your very important public health messages. Over to you, Dr. Gaynor.
Thank you, Ms. Sharon, and hello, everybody. Now, I do have slides, by the way, so do you want those? Is that helpful?
I will say yes if somebody knows how to help me with that.
So who is the host? Are you there,
No,
Carla?
oh, no, somebody.
Carla's
It's disabled.
Is Carla there?
I'm here.
Yeah.
Just make Dr. Watson a co-host.
Yeah.
Please.
Share them.
And then she can share her slides.
Okay.
Yeah. You just give me a thumbs up whenever, Carla, somehow.
I will.
Maybe while Carla's doing it.
I just did it.
Okay. Oh, yeah, there it is. Okay, thank you. Okay, can everybody see that?
Yes. Now we can.
Yes?
Yes.
Yes.
Okay. Great. So there's my title right there. Deputy Chief Medical Officer of Health for the Province of Nova Scotia. That means that I'm second in command to Dr. Strang, who everybody knows, everybody's seen on TV. And so I've been at this coronavirus work now. Veronica mentioned March, and really it was January that the world got the first alert from China to say that something was wrong in Wuhan province, and we've been at it ever since. This is my 3rd pandemic. I was a resident, so I'm a physician. My specialty is public health and preventive medicine. I was in Toronto as a fourth-year resident, pregnant with my first child when SARS hit. Then H1N1, I was the medical officer of health, the senior medical officer of health, the only medical officer of health at the time for what is now Central Zone in Nova Scotia Health Authority, when a little old thing called H1N1 hit for the ship, which was not part of the plan. We all thought it was going to start on the West Coast. That was all of our pandemic plans said pandemic will come into the country through the West Coast, and it came in through Windsor, Nova Scotia. So that was number 2, and this one is number 3. So I'm not going to lie, I'm a little tired of pandemics. Get through this one. So what I'm going to do is just take you through a little bit about what's happening now and get to some bottom lines, and then we'll get into questions as quickly as we can. So back in May, when we were thinking about what the fall might look like, this is what we hoped for. So this slide comes from the Public Health Agency of Canada, which is the big federal public health department that's been overseeing this, and folks will have seen Dr. Teresa Tam and Dr. Howard New giving their daily briefings, just like Dr. Strang does here. They do that for the country. And so they presented this slide to a number of us who sit on weekly calls with them, you know, sort of to say, we think that if we do this well and we keep our controls in place, we may have little outbreaks, but we shouldn't see, or we hope not to see, another big outbreak like the one we had, you know, sort of March, April, May into June. That's what we were hoping for. Real life is panning out a little differently than that. So this slide here represents where we've been since March. And so at the far left of the slide, you'll see wave 1 for Canada, which was that first peak. Then we flattened out. It went almost entirely away in the Atlantic provinces. You'll see that in a second, but in the rest of the country, it never really did. So that's that flat part in the middle. And then it's rising again across the country, but it's not rising in Atlantic Canada. So far, the summary across the country is that Atlantic Canada, I'll show you in a minute. Nunavut has no cases. Yukon has a very low number of cases. Northwest Territories has not had any cases since April. Around the world, the 5 countries where the majority of cases are coming from, not surprisingly, the United States, but then Brazil, India, Russia, and Colombia are where the majority of international cases are coming from. So our strategy in Atlantic Canada was to close the borders. And when I say close, they were never, what we said to them was, if you're going to come here, you need to go into quarantine for 14 days until we know that you don't have COVID, and then feel free to enjoy whatever Atlantic province you want to. That strategy is working for us. So unlike what happened in the rest of Canada, where their activity never really went away, ours has been incredibly low throughout the summer. So this is all full. See that bump? That's New Brunswick last week, when they had that cluster of cases in Moncton and in the Campbellton area. Aside from that, across the Atlantic,
You're breaking
cases,
up.
and that's ultimately, okay, is it better now?
Talk.
Yes, can you hear me now? Yeah?
Yeah.
Okay. So this is the Nova Scotia picture. So again, you know, really since the end of June, basically, we've been on a very, very steady course. Almost no cases in Atlantic Canada. Where we have had in Nova Scotia, where we have had cases, those cases have been coming in from outside of the Atlantic bubble. They've been coming from other provinces, and they've been coming from other parts of the world. So that's what that strategy around the Atlantic bubble has meant for us, is that those cases are coming in, and we are getting 1 or 2 or 3 or 4 of those every week. But because they're going into quarantine, they're not out and about, they're not infecting other people, they're not infecting their family members, and so we're not getting additional cases as a result of that. So we're not seeing the big sort of rise again so far. So when we talked about flattening the curve, somebody might need to go on mute. There we go. When we talked about flattening the curve in wave 1, this is what we meant, right? So our curve was that peak that you see at the far left. We wanted to keep that as low as possible because the higher that curve gets, the more stress there is on our ICU beds and our hospital beds. And they were telling us they could not handle that stress. So we wanted to keep those numbers as low as possible, keep that curve as flat as possible. And then when we got to a flat point on the other side of that, to keep that as flat for as long as we can. And so far we are doing it because of that quarantine policy. People are not able to generate secondary cases. We're not getting spread in our communities, and that's a good thing. This puts us in a bit of a unique position now, and I almost hesitate to say this out loud, especially because I know this is being recorded, but we're in October now, so November, December. The Public Health Agency is starting to send out signals that vaccine could be here as early as the first 3 months of 2021. If we can get to a point where we start immunizing people and the vaccine works, and we're getting immunity from that, then our risk of COVID drops, hopefully, fairly substantially. It's still early days. I'll talk more about the vaccination program in a moment, but there's a possibility that if this pattern holds for us, if the Atlantic bubble holds, we could actually be in a pretty successful position to start immunizing next year when the vaccine's available. I'm crossing my fingers for that, but there's a lot that needs to come together before we have some security that we're going to get a vaccine supply and that the vaccine actually works. I have been talking to my colleagues in other parts of the country where things are not going well. And what they're telling us is a few things very clearly went wrong that they wish they had done differently. So where we left gathering sizes small, they expanded gathering sizes in some cases quite rapidly, up to 500, I think, in some parts of the country. Before their transmission was told, we've seen it every single time. So they started getting new cases generating as a result of that. High-risk activities continued all along in some parts of the country. In other parts of the country, they resumed before that transmission was low, particularly in indoor environments. Gyms in particular are being pointed to as a source of high transmission. And so again, you bring people inside, they're doing forceful, kind of breathing and exhalation because they are exercising. That is a path of transmission for the virus. And so we're seeing outbreaks related to that in other parts of the country. Related to that, we have a sense that we didn't pay enough attention in general, and I think this was true in Nova Scotia too, to this notion that those forceful exhalation activities, shouting and singing in particular, but certainly, the breathing, heavy breathing that you do during exercise, even talking, can generate transmission of COVID. And what's tricky about that is that we're hearing more and more now that is actually, people are at highest risk for that before they even have symptoms of COVID, right? So people think they're okay. They're going about their business. They're singing, they're shouting, now we have people going to hockey games, all that kind of stuff. That's precisely the time where if they have been infected with COVID, they're going to infect other people. And so we're seeing more and more evidence of that, which is unfortunate. In other parts of the country, folks are saying that mandatory masking came late. Well, we did that pretty early in the province of Nova Scotia. And so now they're seeing that they just have too many contacts for every case because people are out and about and they are in contact with people while they're infectious. Here, we still have, because our gathering sizes are small, relatively few contacts per case. That on top of those quarantine rules, again, is making a huge difference. Just to give you an example of how bad it's gotten in some parts of the country, we have heard news reports, some folks will recognize this in Quebec and Ontario now. They are no longer able to contact trace. So they are with a case of COVID to warn them that they've been in contact and to help them get into isolation to prevent them from infecting other people. They have effectively paused that activity because there's no way they can get caught up at this point. And so that's a real risk, right, to community when public health is no longer able to do that. That's how many contacts each cases now generating. And of course, they have a lot of cases. Right? So the keys to success here have been, as I've discussed, we maintained our social distancing and our use of masks. We maintained our hand washing. We limited indoor activities. We're keeping our gathering sizes small. We're asking people still to keep their groups of, their sort of personal bubble small and consistent, and avoiding crowds and crowded spaces, and avoiding generating crowded spaces by opening up broadly, for example, big venues that can host thousands of people at a time. We're doing that fairly cautiously here. We're also hopefully going to continue to maintain a focus on our borders. So I know the Atlantic bubble has been challenging. I have family in PEI. My mother's in a long-term care facility there now. I get the challenge of having to do all of this work to come in and out of the Atlantic bubble. But again, the cases that we have seen here have been from people outside of the bubble. We're not generating cases inside the bubble. And that is having a positive impact on both public health and our hospital system. Curve remains flat. We can go about business relatively well as we have been doing right now. Just so folks know, there is an exceptions process in place. If folks want to come into the Atlantic bubble and they feel they need to be exempted from that quarantine, there is a process that you can ask for that. It may not necessarily be granted, but we are seeing people access that. That's that COVID-19info@novascotia.ca email address. There have definitely been unintended consequences from COVID. And we all know this, and I think Veronica has alluded to already. The first time some national data starting to get generated where we are seeing that addictions, particularly alcohol use, and we think opioid use as well, are on the rise as people try to cope with all of the impacts of COVID. And early on, we recognized that we had a delayed presentation of chronic diseases. So people, I think Veronica alluded to this as well, people were delaying going to hospital, or they couldn't go to hospital, or their primary care provider was closed. And so they had these chronic conditions that needed attention. They waited and waited and waited. And when we finally opened up the hospitals again, what we did see was that those conditions had gotten worse. And so those people, their health had gotten worse. And so that's a real consequence that we hope to mitigate in wave 2. And I'm going to talk about wave 2 in a moment. So by August, the picture had already started to change. And so, wave 1 was predominantly, our biggest worry was, and other closed facilities like shelters and correctional institutes, but they now have protections in place. So hopefully we can continue to keep COVID out of those institutions. Young people, at the beginning, you'll remember we weren't sure why young people weren't getting infected all that much. And certainly the gathering limits in particular were largely what was contributing to that low numbers in young people. Well, as we opened things up across the country, we saw that young people were getting more infected. So by August, that was a fairly clear picture. And that remains the picture. So this is the public health data from just this week. And that second bar from the top is people aged 20 to 29. They represent now the largest proportion of COVID cases, new COVID cases in Canada. So we got to keep an eye on our young people. We got to encourage them to maintain that physical distancing, maintain that hand wash. That's a message that they need to continue to hear. Just going to point out that a lot of this information is available on the Public Health Agency of Canada website. If you're interested, they have these fun little maps. You can actually hover over different provinces and see what's happening right now in real time. And there's the COVID Alert app. If you haven't heard, the federal government has this app that will let you know if you've been in contact with somebody who has been diagnosed with COVID-19. And it's a way of you figuring out whether or not that should prompt you to call 811 to figure out if you should be tested. It's a neat little app. You can download it on any phone. I think that it has an operating system that's within the past 5 years. And Nova Scotia just signed on, I think 2 weeks ago or something like that. So I have the app on my phone. I haven't gotten any alerts yet, but that's because the Atlantic bubble is working. So I don't expect to get any soon, but I'm happy to have the app. just going to turn to a couple of the other things that Sharon mentioned. So with respect to testing, Veronica mentioned early on some of the challenges we had with testing in terms of the delays that it was taking for people to either get tested or get their results back, all that kind of stuff. And so we have been pushing really hard to improve that. I haven't heard the latest concretely, but a few new things are in place that weren't in place before. So we have now, I think, been able to reduce the testing time, at least in Central Zone, and it's starting to spill out now to other parts of the provinces, to 24 hours or less, sometimes a matter of just hours, like 5 or 6 hours, for people to get their results back, depending on the circumstances. We intend to maintain that standard of 24 to 48 hours across the province going forward. So that's where we're headed. And that's for anybody who's symptomatic and anybody who's a contact of a case of COVID who is tested for that reason. We have not opened up testing more broadly than that for asymptomatic people, folks who don't have any COVID symptoms. There is some program now where if you're traveling, you can pay for COVID testing. That's not being run so much by the Department of Health and Wellness, but Nova Scotia Health Authority, I think, has a partnership with Praxis for that. And then we are putting in place now, starting to look at testing programs for high-risk settings, particularly our long-term care facilities. We are going to continue to worry about those until we are out of the woods with COVID. And so some of what we're looking at is whether or not we can institute testing, in particular for staff in those facilities. What we saw in wave 1 was that when it got into long-term care facilities, it was usually from staff. It wasn't from, certainly wasn't from the residents, and very rarely was it from family members. So we have to remember that the staff in our facilities are also part of our communities, right? And they're going in and out and back and forth. And so we want to make sure that we protect the facilities in that way. Our capacity for lab testing has always been good here. We've never had an issue with supplies that the other provinces have had. In fact, I think currently we are helping out Ontario because they continue to have a capacity issue with testing. We've not had that, and we've gotten some federal program funds to further expand our testing. So all of that puts us in good shape. It's not easy. What we don't have is enough human resources to manage the big capacity that we have. We've got all the right supplies and we've got all the right equipment, but we don't actually have enough people to do, for example, the booking of tests, that type of thing. So working on that. So that's where we're at with testing. Now, schools, of course, have opened since wave 1. And that, you know, if any of you have school-age children, you know what a worry that was and what a difficulty it was to get to the point where we could feel confident in opening schools up. This is the Department of Education's back to school plan. If you haven't seen it, at the very back of the plan, there's an appendix that is where the public health guidance is. And that was really where we started, was developing the public health guidance around how we're going to manage COVID if it happens in a school. Public health is going to run its by the book process for schools the way we would for any other outbreak in a school, and we deal with school-based outbreaks of a number of things all the time. And so it is still going to be just like you saw in wave 1, even though schools weren't open, we were doing this for other settings. We are looking for cases, and as soon as we find people who are symptomatic and meet the definition, getting them tested so that we can see if they're positive. If they're positive, then we're going to find their contacts, putting their contacts in isolation, and getting those contacts tested to see if they are now cases. And then if they are now cases, then going on to find their contacts. We will continue to run that routine, whether it's a school or a daycare or a long-term care facility or wherever it is. The challenge for schools will be, does it mean that if, you know, because of the way the schools are set up and cohorting is not perfect and physical distancing is not perfect and mask use is not perfect when you're dealing with kids and school environments, we may see a wider impact of COVID than we would in another setting. So we're preparing for that. The schools are prepared for that. They do have a plan to, for example, move from in-person to some mix of in-person and online, and ultimately to move to online if needed. So we'll see how it goes. I think everybody in the public health system is kind of holding their breath really for the first school-based outbreak to see how it goes, but it's not a routine that we're unfamiliar with either. So we will continue to run our usual process around that because we know it works. The other thing I know is on people's minds is what happens if we get into a second wave. So if we get all of a sudden a huge number of new cases come into the province of Nova Scotia, and I think it will be cases that come in, and they don't quarantine and it spreads, that is likely going to push us into a new curve, a new second wave that we're going to be working to keep it as flat as possible and basically bring to a close as quickly as possible. The challenge with that is that it will depend, what we do at that point will depend on what the scenario is. So what we did in March, closing everything, in some ways is a relatively easy public health step to take. And in some cases, we probably close some things that in hindsight, we might not close in a wave two. I'm thinking outdoor recreation spaces as an example, parks and playgrounds, where we know now that those are relatively low risk. We didn't have that information in wave one, so we closed everything. So there'll be a few things like that that we would keep open. And of course, where we are now is where we hope to stay, as I said, hopefully into early next year. I mean, what we do will depend on where it is and who it's affecting and how big it is. And so what we're hoping is that we'll be able to target what we do so that we don't have to go into full lockdown, for example, across the whole province. But you know, for Levinas, if we see activity in Yarmouth and that activity is only in a long-term care facility in Yarmouth, then what we'll do is work on closures around visitation, that type of thing, for that long-term care facility, not the whole city of Yarmouth. If, on the other hand, we think that it's a number of cases that have happened at the superstore in Yarmouth, that would be a different picture, and that might provoke us to do a number of other things, depending on whether or not those cases seem to be generating now additional cases. That means it's going to spread in Yarmouth if we don't do some kind of, you know, sort of deeper lockdown, if I can put it that way, in Yarmouth. As long as we're not seeing that picture anywhere else, as long as we're not seeing it in Liverpool or in Kentville or anywhere else in the province, then hopefully we won't have to do that in other parts of the province. This is our early thinking, so stay tuned. It's going to evolve. We're in particular watching what's happened in New Brunswick and in conversation with New Brunswick about how they handled Campbellton and Moncton to see what we can learn from that. So that's happening. And then the other thing I know that's on people's minds is influenza. So it's just as if we didn't have enough to think about with COVID, this is flu season. Normally we would be starting to see influenza activity, even a little bit of activity at this time of year, and then we would see a big peak of flu sometime after Christmas is usually when it hits. There's no activity in the province right now, and around the country, there's no flu activity right now, which is unusual. This seems to have been the pattern around the world. We think it's because of the COVID controls that are in place. They are also working to prevent influenza. We need to prevent influenza because the last thing that we want to have happen now is a bunch of people get sick with flu. Those people end up in our ICU beds or our hospital beds, and all of a sudden we get COVID introduced into the province and it spreads, and we have no capacity to look after the COVID cases because there's too much flu in the hospital. So we are really pushing people to get their flu shot this year, critical this year more than any other year. If we get overrun with flu, we will not be able to handle COVID cases when they come in. That's a big deal. So flu immunization has become a major mitigation measure for COVID this year. Because there hasn't been flu activity in other parts of the world, this year's program is based on the virus that was circulating last fall. Sorry, that should say fall 2019, not fall 2010. And so the September update on that seems to suggest that if we are going to get flu, it will be H1N1 and H3N2, which are the flu viruses that are in this year's vaccine. So we think it will be a good match, but there hasn't really been flu activity around the world, and that's in part due to the COVID measures and the immunization programs that other parts of the world have been doing. So get your flu shot. And then I said I'd come back to the notion of COVID immunization, so also early thinking there. If we do get COVID immunizations next spring-ish, the one thing that we'll have to keep in mind is that we are likely to get very, very tiny amounts in each allotment of COVID vaccine. This is going to be really hard for us. So we're going to have to figure out who gets those. We have no information yet as to how the federal government is going to prioritize that. They are working on a statement around that, but how we get vaccine into which people and as quickly as possible is kind of the major focus of our public health planning right now. So more on that to come, but just wanted you to know that we are on it. Just want to put this myth to bed, and David probably has more to say about this than I do. I'm just going to say that for COVID, if in case people are hearing in community or elsewhere that herd immunity with COVID by getting people infected is what we should be doing, please don't do that. Herd immunity for COVID is just not a thing. It just isn't a thing. And the reason it isn't is because herd immunity only works if you have a disease that will give long-lasting immunity so that the immunity sticks. Otherwise, you have to keep infecting yourself in order to maintain that immunity, which is not what we want. This coronavirus, as far as we know yet, does not give long-lasting immunity. So there's no way to get herd immunity in the community. That long-lasting immunity is better with a vaccine currently than it is from catching the virus. As far as we know right now, the virus might give immunity for 3 months, but there's no data on that. And we are hearing case reports of people getting true reinfections from this, even in less time than 3 months. So we really don't know. It does not appear that herd immunity is a thing. So if you are hearing that, feel free to quote me. It's not a thing. Please don't do that. I think that is pretty much all I wanted to say. So my messages to you would be, continue to do what you're doing, continue to keep your guard up for new cases, continue to encourage the quarantine and isolation requirements that must be adhered to in order for us to maintain kind of a COVID-free status in the province of Nova Scotia. We're working on the plans for vulnerable sectors, especially long-term care and other closed sectors, and shoring up our resources for a potential wave 2, which still could get here, but we're hoping that we will be able to ward it off as much as possible. And of course, influenza is the additional threat that we need to avoid. I think that's it. So back to you, Sharon. I hope that is what you thought I was going to.
That is fantastic. Thank you, Dr. Gaynor. That was just really so thorough and easy to understand. And yes, it is terrific to have information like this in a way that, you know, allows us to very comfortably hear it and ask questions. I did see some questions from
Sharon, if I may suggest,
yes.
why don't you let me just continue, because what I'm going to say dovetails into that.
Okay.
And then we can have some questions.
Absolutely.
That's okay?
Go ahead,
Okay.
Dr. David.
All right.
All
So
yours.
just quick introduction. So for those of you who have not met me, Dr. David Haase, retired ID and infectious diseases and internal medicine. And my role on the response and now the impact team in terms of the medical side of things, as you'd heard before, if there are questions that come up in terms of medical advice, we're not giving direct medical advice to people, but helping to point them the way as to, you know, how to find the information. Also a link between community and public health. So, you know, when things need to be done, sort of linking things with public health and the community, I sort of become involved as well. So that's just a brief introduction. So let me just go on, because my piece this evening is really to talk about vaccination, and vaccination including COVID and influenza. So I'm just going to add on to some of the things that Dr. Gaynor has said, which is a sort of nice segue. Herd immunity, let's just, you know, add on something to that as well. So Dr. Gaynor said herd immunity is really when a certain percentage of a population becomes infected and develops natural immunity. Well, you can say even if they're immunized, but we're talking about natural infection. The key thing to remember about herd immunity is you have to survive and have immunity. So if you get an infection and you die from it, you're not going to have that herd immunity. And that's what's happening with COVID. That's one of the things. Not only there probably is not long-term immunity, we don't know yet, but people are dying. So to get to that level where you have, say 60% of the population who are immune, long-standing immunity, we have to get through a lot of deaths first. So it's just not a realistic option. And, there's still people pushing this concept. So I think for us here in Nova Scotia, we want to be very clear. We're not going to depend on herd immunity. So that's one thing. Now let's just talk about COVID vaccine. So you've probably heard there are about 170 groups around the world rushing to develop a vaccine. You heard about Operation Warp Speed, which is the president of the US's thing to develop a vaccine by elections, and then it's going by the end of the year, all that stuff. The reality is, right now, there are probably only about, I think, 30 vaccines in clinical trial, and only 11 of those are in the sort of third phase. They're all looking for safety and effectiveness, efficacy. That's not going to happen really until, I would say, 2021. It may come by the end of the year, really, but most people who are expert in this area think that we will not have a vaccine until early 2021 or maybe early summer. And then you have the issue of getting that vaccine manufactured in enough doses to be able to distribute to your population. As Dr. Watson's creed says, when you get a small amount, who do you give it to first, right? Do you go and say long-term care? Do you give it to, other vulnerable populations? So again, the bottom line is we don't want to hang our hats on a vaccine for COVID. When we have a safe and effective vaccine, it's going to make a huge difference, but it's going to be a while before we can have that level of immunity in our population from a vaccine for COVID to be protective enough to say, we can relax. And even when you have the vaccine, we're still going to have to continue the measures we're doing now. So again, I think we just have to keep our awareness that yes, a vaccine is likely coming at some stage, but let's not wait. Let's keep on going. And yeah, it's very tiring. A lot of people are fatigued, wearing masks and doing this and doing that. But, look at what you've seen from the numbers and, what's going on here in terms of people getting sick from COVID and dying compared with other places. So again, I think it's well worth our while to keep it going. So that's a COVID vaccine. Now let's just talk about the big I, influenza. And it's very interesting. So they're both respiratory viruses, and there's so many parallels, and we don't have time to go through everything, but there's so many parallels between COVID-19 and influenza. And that is going to be one of our problems, because if influenza starts ramping up, the symptoms are so similar to COVID that we're going to have to be able to say, my goodness, which is it? And there are other respiratory viruses as well, which can give you similar symptoms. So, it can become very confusing. But the nice thing is the same measures we're using for COVID-19 are the same measures that are protecting us from these other viruses, including influenza. So if we keep doing those things, the mask wearing, the distancing, the washing of hands, because really transmission is going to be the same. Transmission, symptoms, when we look at people who are vulnerable, there's a slight difference with COVID in that influenza usually is more of a problem in terms of severe disease in the very young and the very old. COVID is right across the board. And you hear about, school-age children, they get COVID. They may not transmit as much among themselves, but they can transmit to others as well. So again, the message is let's stay the course, because these two infections are so similar that if we protect ourselves and others against one of them, we're doing the same for both. And so that's a crucial message for everybody to take away. Influenza vaccine. So, you know, public health beats the drum every year to get influenza vaccine. And people say, why do I need influenza vaccine? Well, you know, it's very simple. If you have influenza vaccine, it's not 100%, maybe 60% protective, but it can protect you from getting the infection. Even if you get the infection, it can protect you from severe disease. And if you think back to 1918, now I wasn't around in 1918, and probably none of you were either, I don't think. If you think back to 1918, there was this pandemic called the Spanish flu. And we can talk about why it's called that. But anyway, 1918 flu pandemic infected 500 million people around the world and killed about 50 million and probably more than 50 million. They had no vaccine. Vaccines didn't come up until the 1940s. So that virus ran through the world population unchecked. These days, we have vaccines which are effective. Now, we don't have a perfect match every year, but there's long-standing immunity. And in fact, there's some year-to-year transfer. And so a vaccine you may take 1 year may help to give you some protection for the next year. People who have been infected with natural influenza infection may have long-standing immunity, which helps to protect them from a strain coming up in the future, because sometimes the strains repeat. So it's very important for us to protect ourselves, because just think, you know, what's going on with COVID-19 and you get influenza on top of that, or, you know, you may not get it yourself, but somebody else in the population gets dual infection, or both infections are rising, we'd be in a really bad place. And so we need to beat that drum to get ourselves and others immunized as well for influenza. Yes, we have therapy for influenza, particularly influenza A. We have no real solid therapy for COVID-19, but we do have a vaccine for influenza, and let's use that because that is protective and that will help us to really, you know, kind of keep things under control. We enjoy the Atlantic bubble. The numbers are very low. So why don't we keep it that way? Because we're all better for it. So Sharon, I'm done. And if there are any questions, we can take them.
Thank you, Dr. Haase. Dr. Gaynor and Dr. Haase, we are very lucky to have them as our HAAC people, always prepared to come and to share this information. And I know I felt like I just got schooled and I just got told I need to get the flu vaccine. Luckily I did. And I certainly hope you all will as well. Yeah. So we are going to have questions at the end, but I really would like to get through and give people time to speak. And then I promise you, we will get to the questions. So Veronica, I'm going to get you to take it for the next couple of speakers.
Okay. Oh, that was awesome, Dr. Gaynor and Dr. Haase. Thank you for that information. And as Sharon has stated, yeah, I guess I'm gonna have to do the flu shot this year. So I'll have to do the right thing. So now we're going to ask our own esteemed, where is she on my screen? There she is, Rhonda Atwell, who works with the Nova Scotia Health Authority. Rhonda, give everybody your title, Rhonda, because it's a new position, one through HAAC. We advocated and fought so hard to put this position, so it's unique. She's the only one of her in the province, and that's what often happens in a lot of the organizations, especially within government. There's one of us, right? To carry all the work. So Rhonda's going to share information about mental health and addictions during COVID and the importance of keeping healthy as well. So turn it over to you, my dear.
Okay, thank you, Veronica. Wow, I feel like I've been schooled too, and I work with public health, and I'm learning. It's very interesting. It's good to hear. So thank you, Dr. Gaynor. Thank you, Dr. Haase. Yes, my title is African Nova Scotian Service Consultant with Public Health, but it's really for all of Nova Scotia Health. My role is just one for the whole province. So you can imagine. I came on and started in March during COVID. That's when I started in this new role. Before that, like Lavinius had mentioned, we worked together with mental health and addictions. I was working as a health promoter for Nova Scotia Health. So it's been a journey. There's lots of work to do. Okay, the need for this position came out of a community request through the African Nova Scotian Health Strategy, which I was the project coordinator for as well. HAAC was heavily involved in that, as well as IWK and ABSW, IWK, ANSA, and yes, and HAAC, like I said. So don't mind me, I'm a little bit tired. So if I stumble or anything, just know it's that.
You're great. You're great.
Thank you. I just want to stay on track. So I do have a few notes here. So I'm also a HAAC board member as well. And I have been for 4 or 5 years now, I think, Sharon. So my role, the African Nova Scotian Service Consultant role, was created specifically to address health disparities within the community, both on a community and systems level. So even though I began during COVID and I was involved in the COVID response, as well as the HAAC and ABSW COVID response team, as public health support and community support, I'm also part of the Preston Township COVID response team as well, which has been instrumental in responding to the community needs as well. So it's been a lot. I've been in this position for 6 months, but it feels like 6 years. That's what I tell everybody. So more coming. I really hope to build capacity around this role. That's the goal throughout the province. So mental health, I'm not going to speak long because we don't have a lot of time and we have a lot of information to cover. I know Karen has to speak. We really want to hear about the schools and the education system. So I am going to talk about mental health. So Veronica, you got me thinking because you had said something about COVID being a hot topic. And it is, right? But anything that's hot can actually lead to burnout, right? It can get hot and you can burn out. And that's what I was thinking. I was feeling like, this is a lot of work. This is a lot that we have to deal with as a community, not just because of the pandemic, but also because of what we've been witnessing worldwide around systemic racism, right? And unveiling of that, even within the healthcare system. So it's heavy on us. It's really heavy on us. And I think we need to take a pause and breathe and recognize that this is a difficult time. So just being here with everyone is also really good for us, right? To connect in any way that we can and to learn and grow together and to support each other. So that's really important to remember. Self-care is huge. So I do have a few notes here. So, and I know a lot of you probably know this, but it's important to remind each other and to be conscious ourselves to, make sure that we're getting enough rest, going to bed on time, waking up on time at the same time, preferably. That does actually help. Making sure that we exercise and take, walks when we can. I know for myself, as I'm sure many of you working from home, I actually work more. Mm-hmm. I don't know how that's happening, but I'm working more and I don't pay attention necessarily to what I'm eating. If I'm eating, sometimes my legs get numb. So I got a Fitbit, okay, for that purpose, because it reminds me to get up, get moving. The body needs to move, right? The body and mind are very, very, very connected. So it's really important that we find ways to move every day. Getting outside is wonderful. I don't do that enough myself. So like I said, I know I'm probably preaching to the choir here, but it is important to remember to do these things and to know that we have, resources available. Like Sharon was, So take advantage of all of those things. Remembering to also stay connected. I don't know about you, but I don't feel as connected to my family. Internally here in the house, yes, but in terms of my sisters live in Ontario, and there's lots going on over there related to COVID. But we don't connect as much as we should. Not everybody is savvy to this new way. We will make phone calls and whatnot, but I used to travel. I don't do that anymore. So being intentional about connecting with those you love and care for is really, really important. So please remember to do that safely, of course. And also, our numbers are low here, that is true, but you may know somebody who has quarantined or has to quarantine, whether they're here or somewhere else. And it's really important to make sure you stay connected to them as well and support them in a safe way as much as you can. Also, we know that we are spiritually driven people in different ways. So whatever way you can connect spiritually is really important for your mental health and wellness. So engage in whatever spiritual practice you have. So whether that's reading the Bible or the Korah or the Torah, prayer, meditation, whatever spiritual talks or music that you can find that make you feel good, do it every chance you get. Do it. Yeah, so I think that's really about all I want to say. I remember, Lavinius, you might remember this, working in health promotion. One of our mantras working with mental health and addictions health promoters is that if you're not taking care of your mental health and well-being, then you're not taking care of your health, right? Mental health is your health. So it's really important. Lavinius, I don't know if there's anything else you want to add to that, because I've been out of that world for a little while, but you're welcome to say something, please.
Well, just to add that there was some data collected during and after that. During the pandemic, we saw that most people reported low mental health during the pandemic, and there was high substance use, alcohol, cannabis, and tobacco. So because of isolation, and many people were just there's some anxiety due to the pandemic. Like, people were so anxious if their loved ones were going to have the pandemic, or if you have even one or two of the symptoms, some stress levels were elevated, and then as a result, as a coping mechanism, NSSC had record sales, not only in Nova Scotia but all over, and the vulnerable population were disproportionately affected as well. So there's been some work around to help people, like the yoga you mentioned, Rhonda, and for people to take care of their mental health.
Mm-hmm.
Yeah,
for sure. Thank you.
Yeah.
Thank you for that. So get moving, everybody. And that's it. Thank you.
Thanks, Rhonda. Okay, so I guess the question I have to ask for folks that just before Rhonda disappears, not that she's going anywhere right now, is how many actually walked today? Who walked? See, three. I see 3 people walked today. Yeah,
Four.
we have to, four. We have to do better. We truly do.
Yeah, we do.
I walk from my car to the office, from the office to the bathroom, from the bathroom to the lunchroom.
Doesn't count, Bernadette.
That doesn't count.
A little bit more, baby. We need more. Thank you for that information. Just a reminder that we do need to take care of ourselves. And yeah, great. Now
you.
we're going to turn our last section over to Ms. Hudson. Karen has been around the education system for many years. I don't want to age her, but and I was really pleased when she came to join us on our COVID team to bring her knowledge and experience in the education sector. As I stated earlier, our Black learners need some help. And so Karen, if you could tell us what the Department of Education and even CASE and ACSD and BEA and DBDLI and all of these other educational resources that we have out there. What is happening for our kids? What are we doing to keep them safe? I mean, Dr. Gaynor went into some of it, but let's hear it from you as our school person, representative.
All right, well, good evening, and thank you, Veronica and Sharon, and all the members of the HAAC response team, or ABSW as well, and other previous speakers. And Dr. Gaynor actually mentioned a little bit in terms of some of the protocols that we try to adhere to, such as wearing the mask and social distancing within the schools. And that is hard. We make it easy because we as administrators, so I'm an administrator at one of the high schools there, we are basically walking nonstop. So we're not at our computers or in the office that much. We are out there ensuring that students, when they enter the building, from the time they are dropped off by the bus or cars, remember, because parents are not allowed in the school, so we're not allowed to have visitors. We just open it up back to our School Plus team, our social workers, who are allowed to go and visit maybe 2 schools, and some of them have like 10 schools, but they have to, we're trying to keep the transmission down so we don't go from school to school. So we've been just given that permission now for the social workers and to travel to other schools. But from the time the students enter into the school, they have to wear their masks. So we are at the doors and we are sanitizing their hands to ensure they do it. So we do the little children, the junior highs, right up to the high schools. And every time they enter into a classroom, they have to sanitize their hands. And we try to keep them within the cohorts or within their groups. But that's difficult as well. It's a little bit more easier within the elementary schools because they stay within the cohort. But when you get to the junior highs and the high school, it's kind of difficult to keep them within their cohorts. They say to us, and one of the things is that when I was listening to Dr. Gaynor and also Dr. Haase in terms of, vaccine and then, wearing your mask and keeping those protocols, adhering to those at all time is, how to wear it properly. And we have all the posters that ABSW and HAAC did, which are beautiful in African Nova Scotian affairs in our school, because we want to be representative of all our children, and we show them properly how to wear the mask. So the children are walking with the mask like this. I say, and I heard Miss Dr. Gaynor say that, it's got to be covering here in terms of singing and, breathing and talking, all of this. You got to protect this. So as they come in, he said, protect your nose. When you come in, wear your mask properly, not here, because it's not protecting anything. So this is something that we have to do on a constant basis. So the first day we went into school, that Friday, we were exhausted. Everyone that was there, we actually went straight home. We couldn't even, and I heard what Rhonda said about taking self-care. We had to go to bed, take a shower, whatever, because that week we were exhausted. What I find right now is that students are relaxing. They're getting complacent because of the numbers are low. And so I was thinking when both the doctors were speaking, I need to get them to come in and speak to our children, but not come in because you're not allowed, but maybe because of essential workers. But I'm not even sure because we don't even have youth health centers up and running now. So that's all closed as well. So that mental health piece is very critical, but we don't have our youth health centers up. So the social workers and the School Plus are the ones that we have to lean on. So I'm just thinking that they need to come in, maybe through Zoom or through our Google Meets, so that the students could hear. We encourage the students to stay within 10 and not to go over 10 when they go outside. And if they go more than 10, we say, please keep your masks on. And then we have to go outside and try to separate them. So that's what we're doing. And students, because the classes are longer now, because we want to make sure that we could eliminate or reduce the numbers of students within the building at once. So we changed our schedule, and so that changed a little bit, which became a little bit longer for teachers and students. So you have to take a break, like a mental break, get up, walk, do something. Lunchtime, our children want to be social. They say, well, we're with our cohorts, or we're with these individuals, you know, when we go out, why can't we go out for high schools? Why can't we bring our food in? Why can't we eat together? We're going to Subway, we're going to Tim Hortons to get this. And so it's a constant reminder every day about hand sanitizing, wearing your mask, keeping your social distance. But one of the things that we try to do is that, just to try to keep it going, is that we remind the parents, and a lot of communication went out about daily checklists. So we have a daily checklist to monitor if families or staff are having any of COVID symptoms, or if you think you could be experiencing. So we go through how you cough properly, sore throat, headaches, in terms of muscle aches, all these things here. So they have to do a daily check before they come to school. Parents, we rely on parents to do that before the child comes to school, just to monitor your child's health. We also have, if a child is feeling sick or ill and they're at school, we have an isolation room where we have to put them somewhere until we call a parent or guardian and say, this is what's happening. And then again, of course, we still have our masks on. They go into an isolation room. So each school had to come up with a place where the child, if they're feeling any symptoms, would go there feeling sick to the stomach or headache or some of those symptoms there, fatigue. We put them in that room. We would call the parent. And then when the parent comes, we will escort the child out. The parent's not allowed to come into the building because we're trying to keep our space as clean as possible. This year, we also had to get additional custodians to help us. So when children are eating within our lunchrooms or in the classrooms, the custodians are going around and cleansing them to make sure that they are clean. So they're trying to keep it as clean as possible. The other thing that we've been doing a lot, and I mentioned it just earlier, just briefly, is about online learning and the virtual school. So if we have to go into, I think Dr. Gaynor talked about scenario B, which is called blended learning. So what will happen is, and it's not all the way this should be, there's a lot of logistic issues that we're working on through that, or a scenario C, which is completely online for high school, possibly junior highs. Elementary would go into the bigger schools and for the blended learning, and then the teachers would be there. So we're trying to figure out, okay, so what part of the school would they use? What part of the school would the teachers use to deliver their online learning? So one of the things that we're doing is that right now, starting, which we did in terms of the, when we were response team, now we're impact team, is that we gave out Chromebooks. We're giving out Chromebooks, and across the province, they've also, Cape Breton and the Valleys and Digby and other areas, they've actually given out their Chromebooks. We've actually finished ours up now in terms of giving them, because you're not allowed to use lockers. If there's a second wave, there will be no opportunity to return to the school to get a Chromebook. So we've actually loaned Chromebooks out to students until June of 2021. So any child, if you know of anyone who does not have a Chromebook, and we keep saying to them, if your parent or guardian or grandparents, whoever's taking care of you, they're working from home, they need their own laptop. If you have siblings, they need their own. You need your own, because it's not going to be the same way it was last time, where you were given marks based on March the 20th, whatever your mark was, that was it. You will have to go online based on your particular schedule for the school that you go to and log on, and they will be giving you work, doing the lessons from there virtually. And teachers are actually getting training in terms of Google Classroom, Google Hangout, Google Meet. Some of the Jam boards, we're also learning how to use some of the technology so that they're up to par, that helps to be more interactive in terms of what happened before. The other thing that we do have is that we have a response team. We just got this notification that came out today. So we have a COVID response team where they're going to be meeting with the administrators. We have to come up with that. So it's a liaison with the Nova Scotia or the Regional Medical Office of Health, and then somebody from the team. And then we'll be doing our school profile so that we know what to do in case that they have to shut down the school. I do have to say two other things, because I'm just keeping track of the time, is even though parents cannot come into the school, it's still critical that we have involvement of parents. They need to know what's happening for their children. They need to be constantly engaged and questioning, because we have a lot of children and students who are feeling mental health. They're feeling some sense of bullying, could be social withdrawal, and anxiety, depression. All of these things still exist. They have not gone anywhere. And because of COVID took place, it exposed what our African, Black, Nova Scotia learners, African Canadians, the discrepancy in terms of what they were receiving based on what they have to do to catch up. And the big thing that Rhonda mentioned, and I got to speak about it, is that the systemic barriers and the inequities that exist. And since the Black Lives Matter movement, that has opened the eyes for some children. But what has happened is that children are now saying that they're kind of frustrated, because they're saying it's not going to change. So it's almost, you see a sense of, they you know, that in their lifetime will they see the equities that they deserve. And so I only mentioned it is because it's been on my mind in terms of how do you make sure that our students feel that they're entitled to know who they are and understand how important and valuable they are and unique to our schools, and that the schools were not developed for them, during African Nova Scotians, and that they have the right to make sure that they are seen throughout the curriculum in every aspect of them. How do we communicate to them the historical legacies, the traumas that exist for them, so that the students know that our goal is to make sure that you feel empowered and that you feel that you're represented at all levels. Even though you may not have teachers that look like you, how do you do that? So today I was actually having those conversations, and I was feeling kind of, heavy myself, because that's how they were feeling. And I was just feeling that, I was saying that, no, these are things that we have to change, that you've been in the system for so long, and they didn't feel this way towards you. So why are you feeling that way? And they were feeling a little bit hurt, right? That, trying to change things in terms of how do you integrate their culture, meaning Black culture, into the school system. And they're saying, Ms. Hudson, but I feel bad for, our white students, our Caucasian students that are there. And I was saying, but I guess I see it as part of your growth, mindset, self-knowledge, self-awareness. And so that's what the conversation that we have to have with our children every day, about self-awareness about COVID, but self-awareness about who they are as Blacks within our system. And I'll stop there because I know that the time is running, but we just got to empower our children, empower our parents so that they feel comfortable. So that we go to either blended or virtual, that they feel comfortable with what we're doing and laying out for them. Don't tell them not to be afraid to call and use the media that they have given to us right now. So just because they can't go to school, they still can be informed of what's taking place. So thank you, Veronica and Sharon. I'm sorry I went so quickly, but.
Oh, that's great. Thank you so much, Karen. Yeah, that's, my heart aches for our little ones. Even Dr. Gaynor had mentioned how, they're carrying the weight of the world. They're seeing all of this. We used to think it as well, seeing, oh, things going to change. And we say, oh, yeah, it's got better. But they see so much of what's happening right now, people dying, and it's hard on them. It truly is. So now, Miss Sharon.
Yes, I would just say, and we're going to get to the questions. We've got a few more minutes left. I was just going to say that, Karen, you're an amazing role model for the children that you are teaching and that you are leading, and that we are called to do is to be loving role models to all of our children. It does take a village. So each of us has a role to play. And that is where we will feel stronger, and they will too. Just want to say that. So let us move on to questions. Sister Veronica, if you could identify the question, I'll channel it where it needs to go. I'll do the triage. So I'll leave it over to you to get the questions.
Okay, does COVID-19 mutate? And we hear of people getting COVID-19 twice.
Dr. Gaynor, Dr. Haase. Somebody.
Yeah, so you know, a lot of these viruses do change, and some of the changes are very minor shifts, genetic shifts, and some of them are major. So I think it's been known for a while that COVID, like influenza, does have some minor shifts. But the cases, there are a few cases that have been reported, where the person had COVID and then came back and had COVID again a second time. And when they looked at the two viruses, they were completely different genetically. So again, it's very early on. We don't know a whole lot about that, but there may be, you know, that sort of chance of second infection. And the question is it a totally different virus? Was the person immune from the first infection? You know, there are a lot of questions. So still early. There's, you know, yeah, no definitive answer right now.
Okay.
Again, I don't know if you want to
Yeah,
add
so
to
the only thing I would add, the only thing I would add to that, David, is that when we have seen those shifts in the virus, they don't seem to be making the virus necessarily more deadly. And I know people worry about that. Is it going to mutate into something worse? Often when we see those shifts in viruses, it actually mutates into something that's maybe easier to catch, but overall less deadly than the original versions of the virus. Coronavirus doesn't seem to be getting less deadly either. It's not getting more deadly, it's not getting less deadly. It does seem to be getting a little bit easier to catch as it mutates in those even small ways, as David has pointed. So we are seeing some early reports, David's right, around people getting second infections. Folks will remember that we reported one here in the province of Nova Scotia. At the end of the day, our analysis was inconclusive. We don't know if that's what really happened in that particular case, but we are on the lookout for it. And I come back to that's why we don't have any confidence in herd immunity as a strategy.
This one wasn't in the chat, Sharon, but there's a question in terms of vaccine stigmas. So is there information out there, especially within the African Canadian or African Nova Scotian communities? You know, there's this little reluctancy to get tested for anything. Do we have some information to put people, to assure them that this vaccine that is being developed is not going, we're not going to be used as tests or samples, or we know what happened in the Tuskegee case, right? So
yes.
Do you know what I mean? Like,
oh yes, it's an issue. It has been an issue for many years that there is a you know, even a movement actually among many people, not only Black people, lots and lots of other people who are, it's called the anti-vax you know, movement kind of thing. And the problem is, and I'm going to give this to Dr. David, the problem is, unfortunately, we as Black people are extremely vulnerable, and we have, you know, high rates of chronic disease, and we actually need vaccines to help us. Dr. David, can you talk about
well, so we need to be very, very clear on what is going on when you develop a vaccine. And a huge part of it is making sure that it's safe and it's effective. Okay, a huge part of it. So when you get to what we call phase 3 trials, thousands of people ideally need to have that vaccine for safety and very importantly, efficacy, right? The problem is if you do not have representative numbers from all populations, then when you're ready to roll that vaccine out, you may not be truly able to say it works in all populations. So in the vaccine trials, you need to have representation from people of African descent to make sure that this vaccine works for them as well and is safe. You know, so when people talk about being guinea pigs, I mean, you need to draw a line because that vaccine, we need to be part of the clinical trials. Otherwise, you know, when they roll that vaccine out, you haven't tried it enough. To remember as well is when they develop these vaccines, there's a stepwise process. So they give it to small numbers of people first. There's different phases, and we don't need to go through all of that. But they need to they go for safety data first to make sure it's safe. If there's any concern about safety, those trials are stopped. They'll analyze all those things. So, you know, people are scared to take the vaccine in a research setting. Oftentimes when it comes to that level, they've proven that it's safe already. Otherwise, they'll not be allowed to continue the trials. So we do need to be representative. So, you know, it's a struggle for me when people say, you know, we don't want to be guinea pigs. But in fact, we need to be upfront in representation in research trials as well. And that's not just for this vaccine, but for a lot of other things. It's like having, you know, drug trials where you don't have women represented. And then you roll out this drug, and does it work in women? Is it safe in women? So again, you know, anyway, enough said, but I hope that's clear. I hope that's clear.
Yes. So I see Miss Bernadette has a couple questions. So we started a little bit late, remember, folks? So if you allow us to go to 8:35, then we can probably get all these questions in, because I see there's another one in the chat as well. Miss Bernadette.
Thanks, Veronica. I just find sometimes typing is so much. So my first question is to Dr. Gaynor. When you talked about the app, can you explain a little bit about how it works that allows you to know if you're COVID contact or whatever you had mentioned there earlier? I'm a little confused as to how you know if you're in contact of your COVID. Yes.
Dr. Gaynor?
Yeah, sure. So thanks for the question, Bernadette. So when the province signs on to the app, they enter into an agreement with the app developer and the public health agency that allows any positive lab test to be given a key. So it's an electronic, basically, marker. And that's all it is. It doesn't have any identifying information. It doesn't record the name of the person who has the positive test or anything like that. But whenever the lab generates a positive test, they get this key. The key goes into the background programming of the app and then looks for who is around the person who has that key for 15 minutes in the previous whatever time frame. So, you know, 48 hours before the test or 48 hours before they had symptoms, because the person who gets the key also puts some information about when they got symptoms into the app themselves. Once that's done, it sends out basically that ping. And if you have the app, you'll get pinged. Somebody in your vicinity has a positive test and you were in their vicinity sometime in the past day or for however long, type of thing. That's all it does. So it doesn't give you any information about who. It doesn't give you any specific information about where. It just says you have been in the vicinity of somebody who had a positive COVID test. From a public health perspective, this is not particularly helpful, I gotta say. However, it does at least prompt members of the public to call 811 and find out, you know, the app said that I've been exposed. I don't have any symptoms or I do have symptoms. Based on that, should I get tested? And then 811 will take you through the rest. So it's not a contact tracing app. It's not, you know, collecting any personal information about anybody who uses the app. Some would say that's one of the flaws, but it's also one of the privacy protections. So I get why they went there. Not generating a lot of public health data, but it gives the public just a little bit more information than they would have without the app.
So for me as an individual, if I got a ping, I would kind of like think about who I was around maybe. And that might give me an idea of, yeah, possibly.
Think about who you're around and, you know, depending on whether or not you have symptoms or how concerned you are, you might call 811.
Okay. And my other question is for Karen about the Chromebooks for parents and children. So right now you said that children get them. I mean, the system is, but if parents are in need, because you said each individual in the household should have their own. They shouldn't be sharing them. Is there a process where parents can borrow from schools? Or is there a process where I know HAAC and ABSW may be getting some more, but I mean, most of those sounds like they're going into the rural area. And then Sharon also mentioned there's some more coming down the pipeline 98. Are they going to be available to community?
No. They're spoken for, Bernadette. They're going into the rural areas, just to be clear.
Right, okay.
Yeah.
You know, I can raise that question, because if a parent doesn't have it and the student has it, and then they're trying to utilize that Chromebook, but the parent doesn't really know how to use it, we actually asked for like a possibility where we could do some training for parents so that they're able to work with their students, especially at the lower level. Junior high and senior high, they're actually pretty good to work with their Chromebooks. But if a parent doesn't have that, so I could find that out, because there are some parents who cannot afford that. And I know last time ABSW and HAAC, they did assist in terms of making sure that through the COVID response team, we actually made sure that there was a Chromebook for the family or for those students. But I can find that out through the different divisions if they're going to do that. Right now, their priority was to give to high schools, and they're going down. So we actually had to do profile of who had technology within their household, and then we had to place it in power school so that we could be able to have a correct analysis of what's what.
Okay.
So good question, but I can find out for you. I can pose it, because we do have a principals meeting coming up this week, so that will be something I will find out, and then maybe when we have our meeting, the impact team, I can let them know.
Okay, thank you. And my last one, Veronica, it's just the acronym, Dr. Gaynor, that you gave for Canadian Standards, or CAAC, or what do you call that one?
Hi.
HAAC. What does it stand for?
Yeah. Canadian Institute for Health Information.
Okay, thank you, Bernadette. You said 2 and you took 3.
That was the other people's explanations.
Okay, over to you again, Sharon.
All right. If there aren't any others, then
there was one other.
Was there one more? Okay.
Yeah.
What is that?
There's one thing, but how do you get a good complement of Black persons to participate in a clinical trial without them being made to feel like test subjects?
Well,
yeah, so the key thing for vaccine trials, and there was one going on here, but it was stopped, is that when they advertise to get people to come into the trial, they wouldn't go to one specific community and say, okay, we're coming to your community, we need you to be subjects for this trial. They would advertise to the entire broad community, and within that, they would want to have people representing different communities to come in. So it's not like just one, say, African Nova Scotian community going in. It would be African Nova Scotians and Indigenous people, and all. So it really is a broad ask, but in that ask, they would hope that they have representation from the different population groups.
Can I just make a point too before we close, and that is that those of us who understand, those of us who are informed, really do have to be role models, and we should be participating in research for our people in ways that we can. I'm not talking about taking risks, but in some cases being interviewed, being part of research. It's very important, because the whole reason that HAAC exists is because we as Black people have not been focused on, we have not had culturally specific approaches and culturally competent approaches. And so we need to be part of this. We have, as you see on the call, look at all the people, look at all the resources, look at all the medical people and all of the health people. And, we have an amazing group of people here. We could lead this country with the kind of people that we have. So we need to do our own research and have our own information so that we can be healthier. So I think we need to, those of us who can, should go forward and lead. That's what I think. That's my opinion. Anyway, Having said all of that, I really want to tell you that we have been very, very honored to have all of you with us this evening. For the speakers, you've been amazing. I think this is one of the most useful, informative sessions that we've had, and it's going to be available. Carla is so good about that. It's going to be available on the HAAC web Facebook, right, Carla? So that people can go and see it again, and have other people come and see it so that they can learn as well. Okay, so with all of that, I just want to leave you with the idea that you must stay safe. We must continue to be vigilant so that we can keep these numbers low. We need to treat each other with love and kindness, help somebody, be there for other people, and be those role models and those leaders that we are destined to be. We love you. HAAC is there for you. This initiative with ABSW and HAAC is there. The toll-free line is there. We're not going anywhere. We're going to see it through to the end. So thank you so much, everyone. Have a marvelous weekend. God bless.
Thank you.
Thank you,
too.
everyone.
Right,
Take
everyone.
good care.
Thank you.